this evening. We have a special guest with us, Sarah Harker. She's our business development manager. She's going to be moderating questions, and if you have those, please put those in the Q&A throughout the evening, and we will get to those through our discussion with Dr. Williams. I'm your host, Susan Bavisoto. I'm the client advocate here at Freedom Healthworks. I've worked for the past about 20 plus years helping physicians like Dr. Williams launch their direct care practices. I was at ground zero launching the first DPC practice in the country in 2001. I've helped expand other networks of DPC practices to about 500. I joined Freedom Healthworks in 2019 due to COVID and my kids being sent home from school. But I'm so glad to be a part of healthcare change in America and Freedom Healthworks. They're doing great things in the DPC space and supporting practices across the country. All right, so let's jump in. We're excited to announce our guest tonight, Dr. Edward Williams. He was born and raised in Mobile, Alabama. He went to high school at UMS Wright in Mobile, Alabama. He did his undergraduate at University of Alabama. He completed his medical school at the University of Medicine and Health Science in St. Kitts. His residency at Catawba Medical Care in Centerville, Alabama. He was a chief resident as an upper level. He's board certified in family medicine. He was the attending physician at South Baldwin Medical Center in 2019-2020. He resigned in 2020 to start Foundation Direct Primary Care in late 2020. He opened his doors to see his first patient in January of 2021. He lives in South Alabama with his wife, Tammy, and their 3 kids. When he's not working seeing patients, he's in the woods chasing deer or turkeys, or maybe his kids around. Welcome. Thanks for being here, Dr. Williams. We're glad to have you.
Thank you for having me.
Awesome. So let's get started. We would like to know why you decided to leave hospital employment. I'm sure there's a great story there.
Yeah. How long do we have? I'll give you the abbreviated version. I just started working for I won't name the hospital down here, but it's somewhere close to where I live. And I was pretty much taking over for a physician that was retiring. He had been running his own practice for like 25 years down here, and he was thinking about retiring. So the hospital system got wind of it and swooped in like, vultures, and pretty much told him, hey, you're either going to sell to us or we're going to start a practice across the street. So you might as well sell to us. And him, being a intelligent man, said, okay, well, I'll just sell you the practice and retire 3 months after that. So I was the guy that they were hiring to replace him. And so I got to work with him. Great guy. He's doing well, still keep in touch. But as soon as I started working for the hospital system, I mean, coming out of residency, you're very highly trained. That's probably the smartest you're ever going to be. And in residency, they let you do a lot of different stuff. And especially in my program, I only went to 1. Don't know why you want to do 2. But at my program, they let you do a ton of stuff, from running the ED to running the nursing home, running your own clinics and in their practice. But so I came into it knowing how to do a lot of things, and quickly found out that they wanted to hamstring me to the point of where I was probably practicing at like 15% of what I could do, and it was just boring me to death seeing all these Medicare annual wellness visits all day. And so I was coming up with stuff to make my clinic run smoothly and efficiently and get as many people in and get as many people out, just like I thought I was supposed to do. And every little thing I did, they would come in and go, no, you can't do that. We have to run it up through our committee to make sure it's okay for you to do. And it was stuff like trying to get all my Coumadin patients and, get them all lined up and just, get their INRs real quick. And I could do like 30 of them in like 10 minutes. I was like, how is this a problem? This sounds like it would be super efficient. And every time I would do something like that, they would be like, no, we have to have a committee meeting and okay it through your schedule. And, I don't know, me being a little bit of a hothead, kind of somebody said that to me one time. I was like, what do you mean? I can't run my clinic the way I want my clinic to be run? They go, it's not your clinic, it's ours. And I was like, oh, okay. So you came to that, came to that realization like 6 weeks into my career. I was like, okay, well, I'm not going to work for these a-holes the rest of my life. And this was late 2019. It's like November 2019. And so that planted the seed in my head where I was like, okay, I've got my contract. I'll wait out my contract. And so then something happened in like 2020, early 2020. Can't really remember what it was, but like global pandemic or something like that came in, and we didn't know, back then we didn't know if everybody was going to turn into zombies or what. And so most physicians being physicians were like, okay, well, let's just see how it goes. My priority is to keep my patients as safe as possible. And that's how it's going to go. And so March 2020 happens, and like everybody's hair's on fire. And pretty much I looked at my clinic and I was like, well, if you don't need to be in the clinic, I'm going to not get you into the clinic. Let's say it's a lab results or something silly that I can pretty much handle over the phone. Well, I'm going to call you and handle it over the phone. And so I started doing that. Administration comes in and, comes into the office and they're like, Williams, you can't do this. And me being kind of a smart aleck, well, clearly I can, I'm doing it right now. And they would throw a fit saying that they can't bill for, me calling somebody on the phone. And I pretty much used words similar to, I don't care. This is what's best for my patient kind of attitude. And lo and behold, a couple of weeks later, CMS or whoever's in charge of something, swipes a pen and says it's okay to do telemedicine at this point. And so things change very rapidly when they need to. But I was doing it, I'm not saying illegally, I'm just saying frowned upon. They couldn't get paid for what I was doing, so they didn't like that at all. But it was dawning on me that there's better ways to do things that the insurance companies don't pay for or won't pay for or what have you. The other thing that kind of got me, let's just say, I don't know, reprimanded. That might be too strong of a word, but another thing I would do during the pandemic was if it was a sick visit, I'd say, yeah, park under the tree. I'll come outside and I'll see you. You don't have to come into the clinic.
Oh no, they probably were not happy with you at that moment.
So once again, they come in and say, Williams, you can't do that. We need to have them in the clinic. And I said, well, clearly I can. I'm doing it. You can watch me. Not that hard. I take the little stethoscope thingy and go out there and, get their vitals and make a decision. Most of the time that's okay. But yeah, once again, they were like, no, you can't do that. We have to have them in the clinic. I understand how they get billed. So I understand where they were coming from. Mm-hmm. But it's not the best for my patient. And at that point, they come in and they got a little angry. Maybe some voices were raised, and they started calling me names, which I'm okay with. I've been called worse by better people. They said they can't have a cowboy working out in their outpatient clinics, and my staff overheard me go, the only regret I have is that I'm not wearing my boots today. And that's what I want to go on my epitaph whenever I go down. But that was one part of it. And then no one was coming into the clinic, and so I was seeing like 4 patients a day. It was nuts. But since I was a good little employee and had to be, at my work site
Mhm.
on station for however long they wanted me to, I would sit in my office and I was researching ways to get out. And I'm not sure I should be telling you all this, but you get CME money when you're working for these kind of people. And with my CME money, I went to the virtual, I think it might have been the virtual DPC conference after stumbling upon it, and attended that, and then came out with a business plan that I wanted to implement. And then shortly thereafter turned in my resignation. So they pretty much paid me to research how to get out. And kind of the rest is history. I turned in my resignation on September 1st, 2020, and then was done December 1st, 2020, and then opened my doors with Foundation DPC pretty much January 4th of 2021. So
Sure.
it's kind of that's the gist of it, I guess.
Yeah.
Trying to
So-
keep it PG-13 here.
So let me ask you a quick question. When you were at the hospital, when you were dealing with patient care versus what you're dealing with patient care today,
Mhm.
can you touch on that a little bit about the differences of how your journey was with patient care and seeing just patients as a whole in the system versus how your patient journey is now with those patients?
So yeah, don't get me wrong. I mean, doctors in the system, doctors aren't who I really have problems with. It's the administrators and, insurance companies and the government trying to be me, trying to be the doctor. So the patient care that I was providing when I was in the system was the best I could do. I just didn't know there was any other options. I would do whatever I could for my patient with what I had, with the time allotted, with my, so whatever I could do, I would do the best I could. So as far as how I feel it was delivered, I was doing it. I think it was okay. I mean, as far as I can tell, didn't have too many complaints, but as far as what I'm doing now is like 10 times just more efficient, more, you're very in tune with who your patients are because you're not forced to see 30 people a day. You see, maybe 10. You know them personally because you've got the time to do that. So I feel like my patient care now is just more enhanced, but I feel like my patient care back in the day, I mean, it wasn't horrible. I just didn't know there was a better way. So it was the best it could have been for what it was worth. The more experience you get, and especially if you're in DPC, you know what I'm talking about. It's just unbelievable at what it can be. You just don't know what it can be when you're in the system, or maybe you do know and you're ignoring that. That's a whole different kind of story, but it's pretty unbelievable now, I would say.
Great.
We've got a question here in the chat box, Dr. Williams, asking how you researched to start on your own, and did you do it on your own? Is the question when you decided to leave.
No. So I researched it by using the Google machine, and a lot of it was coming up with like concierge or independent practice. And I just made a list, and DPC was on the list. So I made a list of independent practice, how to do that kind of stuff. You'd still have to use insurance and go down that route. Concierge, you're gonna charge a pretty much retainer fee and then go back most of the time, then go back and bill their insurance. And that was more geared towards the affluent and more kind of wealthy population. And a big part of what I was doing is, I know we didn't get into the story, but I was seeing a lot of cash patients when they couldn't afford it. I would say, just take it off of, bill me essentially. I don't care. I just want to, see this person that needs me. And so that led me down the path of DPC. And then, you go down that rabbit hole of what it is, how to set it up. And then I went to the DPC conference. And then I ran into like how to, start the business, like what you needed to do as far as that goes. And then I took a step back and I was like, okay, this is going to be a lot harder than I anticipated. I didn't trust myself at that point because I'd gone down the, fee for service rabbit hole with my employer. So like personally, I didn't trust my own decision making at that point to start a business. We're doctors. We don't get trained in these kind of things. And at the conference, I ran into Freedom Healthworks, and there just was setting up, ding dongs like me to start their own practice. And I was like,
that's our new tap.
There's a couple of things I'm good at. One of them is not starting a small business. And if you can, have at it. Good for you. That's not me. There are plenty of things, there's what's the saying? You don't know what you don't know. There's a lot that I don't know, and I did not want to stumble into it the hard way, because one way or the other, you're going to pay for it. And I just knew that I was not going to get through that process without stumbling a couple of times. And, Freedom, I mean, that's what they do. They set people up with their practice ready to go. They give you the advice to open your doors, and then they just kind of, they're the training wheels. And once the training wheels come off, it's all up to you. But without that support, there's no way I would have been able to, make it through that. I mean, taxes and laws, and my God, like there's different taxes for what neighborhood you're in around here. This is just total BS. But I know that would have been a problem had I not gone down that route. Anyway, hopefully that rambling answer helped.
Yeah, there's another question piggybacking off of that. What's the greatest business lesson that you've learned coming from hospital to DPC?
All of them. I didn't get any
All of them.
business. Yeah, I mean, I'm a doctor. There's no business involved. So when I went to that outpatient facility, there was no marketing. I was getting a fight with them because they wouldn't put up a sign that said I was even existing back in the neighborhood where I was. So that was the gist of my marketing experience, was trying to get them to put up a freaking sign that had, where my clinic was located. But everything business wise was learned after I started down the DPC journey, because it's your clinic. You're still a doctor, but hey, now you're an entrepreneur. Now you're a small business owner. So you have to play that game too. That's not a game that I thought I would ever have to do. Otherwise I would have taken probably a class or two in undergrad, but we're pretty smart. We pick it up fast. Most of us are pretty smart. Most of us pick it up fast. I'll correct that. But it's been fun. I mean, it's just a new angle, and I'm pretty introverted. But that was, before I had to be a business owner and get out and show yourself and sell yourself. So I'd say like everything had to be learned after I got out of the system, but it's been awesome. So no, I don't have a problem with it.
That's great.
What else you got?
We've got a couple questions back to the hospital. One person's wanting to know, how does your salary compare? Are you comfortable sharing that a little bit about that?
Okay. Yeah. Right to the heart.
They're not holding back.
They're coming at you here.
So now it's comparable. When I was in fee for service, I was getting paid. We're just being honest here. We're all friends here. I have no idea who's on the other side of the computer.
3,000 people. Just kidding.
3,000 people. Great. I think I was getting paid $185 a year. That was with certain stipulations and with certain kind of that was the first year salary, and then it turned into just straight up RVUs. So my first year was 185, and then it was turned into RVU based kind of reimbursement, which is pretty standard. A lot of people do like a base salary plus RVU. But as far as after, so once back into when I first got the inkling I wasn't going to work for them, I started like squirreling away money, which I think was a brilliant idea. I didn't know the pandemic was going to be there. But anyway, I started squirreling away money. I told my wife, I was like, hey, sorry, we're going to have to live like a resident for, a little bit longer. So I was taking a lot of money out of the hospital paychecks and just squirreling it away, knowing that if I was going to start up a new clinic, then we're going to go, probably not going to go out to eat 5 times a week, So that first year I was taking into account, maybe I'm not going to get paid, $200,000 while I'm trying to get this up and running. And that's true when you are starting your own practice. And there's plenty of DPC stories out there that they're like, day one, I had 180 people sign up. I'm like, great, good for you, buddy.
Yeah.
I didn't. I had 30. So I had 30. It took me 6 months to maybe less, around 6 months. Susan probably knows this, but around 6 months to where I was covering all my overhead. So like diapers to, the rent for my clinic, everything I could do at the clinic and at my house, covering mortgage, all that I broke even at about 6 months. After that, you start enhancing the clinic and you can start paying yourself. And everybody's story is different. I mean, some people, they're breaking even when they open their doors. They're making money when they open their doors. And then others, the not so successful stories, and I don't know what happens with them, but they're still 3 years into it and they're not able to pay their overhead or something like that. But we can get more on that and like how to minimize your overhead and not wasting money on stupid stuff that makes it difficult. But yeah, for me, this year I plan on paying myself probably more than I was. Well, I didn't pay myself when I was fee for service, but I'll be able to make as much money this year as the last year I was in fee for service. Next year, I would expect to be just fine. So
Thanks for sharing that and being
Yeah, that's great. Mm-hmm.
Yeah, I think there's a lot of questions here regarding the hospital. People, we must have a big hospital crowd tonight. People wondering about getting out of their contract. Did you have trouble getting out of your contract with the hospital, or did you have one before you opened your DPC?
yeah, so contracts are a big issue. I would say, if you haven't signed one yet, for the love of God, just read it. You're gonna hear like a million people say that, but do read it. There's going to be something in there that what I had was a non-compete clause, and that was it stated that I couldn't practice medicine within 20 miles of the hospital for 2 years. Now, everybody here knows that the only people that can tell you who can and can't practice medicine is the medical board, but I also know that this big, national hospital system probably has lawyers that could eat my salary in a few seconds. And even if I won that battle, at what cost? So I decided to, just be on the other side of that non-compete for the time allotted. That expires on December 1st of this year. So it's game on. But yeah, read your contracts. It's going to say, if you have a non-compete, have a lawyer look at it, see if they can uphold it. If you haven't signed a contract yet, read through it and see if you can negotiate out a non-compete clause. Sometimes you can, sometimes you can't. Most of the time it doesn't even matter. I know a couple of doctors that are just like, yeah, it's in there, whatever, I'm next door. Okay, that's how you want to float down that river, go for it. But yeah, read your contracts carefully, and if they try to get you to sign something that you're uncomfortable with, just if most of the people probably listening are either, doctors or PAs or nurse practitioners, you have more flexibility than you think you do. They need you more than you need them. So just look into it. And I'm got a couple more days. I can't do the math in my head right now, but it's like 3 more weeks of this non-compete. But I just judged that it was worth, 2 years to get my clinic set up outside the reins of their, domain or whatever. And I was correct. I mean, it took me about 2 years to get to where I am now. So I'm good to go, ready to go back in there and get my old patients, rescue them.
I would just add too, in my experience with dealing with physicians and providers, the non-compete mileage can be a big deal if you're in a very small town, right? Say you're driving 20 minutes from your home to the hospital, vice versa, and then you decide to leave. You want to be that community provider in your community. So really think about that when you're reviewing those contracts and getting ready to sign it, because if you're building a family, if you're building a home, if you're building something into that community and your non-compete is showing you 20, 30 miles, really take that into consideration. Maybe not for this day, but in a year from now or 2 years from now, you really should consider that as part of your lifestyle and what you're going to do going forward if something doesn't work out at the hospital.
For sure. Yeah.
Thanks, Susan.
Sure.
One more question here, and then I want to kind of jump over into your new life. But someone's asking, how did you decide to staff your practice, and how did you decide to select your building? You talked a little bit about having low overhead and focusing on stashing up that cash. What did you say? Squirreling it? So tell us a little bit about how you decided when to grow your staff, or if you have.
So the staff came I try to make everything as automated and as technologically advanced as possible. I know some people are comfortable with that kind of stuff. Some people aren't. So if you're not comfortable with automation and streamlining things, and maybe you're just old school paper chart kind of doc, it's that would probably mean you're going to have some type of helper with, patient 100 versus 250. If it gets to the point, the way I knew that I needed help was that when I was seeing patients in the clinic, I was getting so many, messages and phone calls that I couldn't, devote my time to my patient versus answer, questions on the apps coming in. When that stressed me out to the point of I need to pay somebody to do this, when essentially. And then I just put it out in the universe that I needed some help, and lo and behold, somebody knew somebody that was looking for a job that was similar to this, and I have an awesome MA at this point. And she is happy to be here. We're going through some changes in our EMRs at the moment, and total faith that we'll be able to be even faster and more efficient after this. As far as the location goes, I've got a 800 square foot kind of open room essentially that has 2 little cubby holes. That one has my MA in it, and the other one's like a snack area, storage area, and then kind of got some meds and a lab place that she can draw the labs. I've got a desk and an exam table over there. And I just kind of found it. This was not built to be a medical clinic by any means. I think it was just like an office space before I got a hold of it. And you can, in DPC, you do not need an 8,000 square foot clinic. And that, I would say that's probably a big initial overhead thing, is utilities and rent. you can get away with, and depending on how you practice, everybody's different, but you'd be surprised at how little you need when you start off. I mean, there's a bunch of people just driving around in their car, just doing, house calls, which is cool. But really all I need is a laptop and internet and, my stethoscope. That you could get away with that most days. But as you grow, as you get bigger, you can add new stuff like dispensing, and depending on where you live, what the laws are, you can add dispensing, blood draws, all that good stuff. But if you find a spot that's 400, 600, 800 square feet and you got a desk and an exam table, that's probably all you need.
That would be my recommendation as well. I think when people get into those larger spaces, your expenses start to crash a little bit because you're having to pay that rent and you don't have the volume day one to necessarily support it. So I think the smallest practice that we have right now is in a 550 square foot office space, and they're making it work as well with their MA. So it's definitely doable. I think too, when providers leave the hospital and they have that space, right? They look out and they see all those nurses and all the machines in this huge space. They kind of can't even envision what it would look like in 800 square feet or whatever that even means going into that smaller space. But it's definitely doable. And you really, really need to keep that in mind in your budget when you look at spaces, which Freedom Healthworks, we can help with that too. Help you find a space.
Yeah, another superpower.
Mm-hmm.
We briefly touched on, you mentioned concierge medicine being kind of something that's paired with DPC on occasion. What do you say for the person that thinks DPC is for the wealthy? What's the community that you serve like? What is your kind of standard pricing? And do you feel like it's something that's more just for a wealthy person?
As far as concierge goes, or DPC?
DPC.
Well, when they say is DPC for the wealthy, I say it's for everybody. If it's my clinic, you can decide how much you want to charge somebody. I've allocated 10% of my clinic to charity care. I just know that 10%, I'm okay with 10% of these people not paying me for my service. Now, that qualification is subjective. I make that call by myself. But when you know your patients well enough and you're like, hey, I know they can't even afford to, buy their groceries. That's okay to do. I didn't really do any market research on, my price points. I just kind of worked backwards from how many max patients I wanted to see, and just can't really do it off the top of my head right now. But somehow I came to, if an adult paid me $75 a month, I'd probably be okay. And then worked backwards from there. And that's flexible too. All you got to do, if you want to change something, change it. I mean,
it's yours.
Probably
It's yours.
Yeah.
You don't have to ask anybody.
You don't have to do anything you don't want to. And I knew my, greater than 60-year-olds were going to eat a lot of my time. No offense, but that's just the way it goes. And so they pay a little bit more. They pay, I think $95 a month. But it's up to you to be worth it to them. So blow their socks off. And that's not hard to do with what we do. If you say hello and remember their name and spend more than 5 minutes with them, it's the best doctor visit they've ever had. So that bar is like really low.
Yeah.
So yeah.
Yeah, I like that answer. It's for everybody.
Mm-hmm.
I think that's a really good segue into kind of the lifestyle that our next question is about here. This is from Dane for you, Dr. Williams. So it sounds like you get time to spend in the woods. There's a few rumors around here about turkey hunting, and you get to actually have a hobby. Can you tell us more about your work-life balance?
Yeah. So in residency, there was no work-life balance. It was work until you have no life or it's taken from you. If you're a resident, you know what I'm talking about. God bless you. Godspeed. In fee for service, you were an employee and you traded your time and expertise for a paycheck. Not to get too philosophical on everybody, but I believe that the truest currency is time. That's not something that we can work harder and get more of. What we have is allotted to us. We don't know when it runs out. So a lot of when I was working for fee for service, I was like, man, I'm missing my kids grow up. I'm missing all these things with my wife. What am I doing with my day? I already, gave my 20s to be educated in medicine and my, residency. What am I getting out of that? And when you're working for the system, they don't give a rip. If you died today, they would step over your warm body to replace you. And that was evident with COVID. And when my, colleague retired, I mean, they threw him a donut party after 25 years and said, good luck. And the next day I was running the show. I was like, that's it? Really? Okay. But what I have now is unbelievable. So yeah, everybody needs to pay the bills with US dollars. I get that. But the time I have now to be a dad, be a good husband, be a happier person, it's indescribable. And it is 1,000 times better than I could have imagined had I gone down the other path. I mean, the US dollars, that'll come after enough time, but we don't get our time back. And if I want to block off half a day to, take my kids swimming during the summer, I don't have to ask anybody. I just go. And if my, I'm available. We have our app on our phone. If my patients need me, if it's an emergency or something like that, I'm still available. You don't have to sit in a clinic to be who you are. You're a doctor. You take that with you wherever you go. It doesn't stop when you hit that threshold of the door. But yeah, I mean, as Dane was alluding to, I mean, I can text patients while I'm doing what I love, which is be with my family, or if I'm wandering out in the woods, I have cell phone reception.
We have had calls
do that
in the woods before with Dr. Williams. Yes, we have.
I didn't get anything that day.
It's probably Susan was laughing too loud on the other end.
Probably
Scared the turkeys away.
Yeah, that might have been it.
Yeah. All right. I think, going back to residents, we've talked to a couple people lately in some of the summits that we've seen that have come straight out of residency into DPC. What are your thoughts on that?
Awesome. You are clearly smarter than I was. Yeah, I mean, if you're coming straight out of residency, you are savvy enough to actually know what you're going to, you already know what you're going to do. It's probably going to be a little bit more difficult because your reputation is started from scratch and probably a new area. That's okay. But I mean, if a resident comes straight out of residency, opens their doors, I mean, and if you have 300 people sign up day one, like, share that magic. I don't know what you're doing, but like, let us know. But that's okay. Yeah, go for it. There's always going to be naysayers. Don't listen to them. If you can do it your way, have at it. There's always going to be somebody that does it better, or you shouldn't do it that way because that's not how they did it. If you can figure it out, go for it. If you need help, that's what we're here for. I mean, DPC community is pretty awesome. If you ever have a question, you can find a dozen of us that would be willing to help. But if you can do it straight out of residency, go for it. If you need help, that's what we're here for. No worries. If you're in fee for service and you want to get out, you want to escape, come over to the rebellion. We can do that too.
All right. Here's a question for both of you, actually. You mentioned being introverted, and what's your advice for people who are introverted? Is it possible to make it work in DPC on your own? Or what do you have to do to make it? I think they're trying to ask, what do you recommend doing if you're an introverted person and still trying to make DPC work for you?
So yeah, the proof is in the pudding. I'm introverted and this thing's working like a charm. You can develop skills. So read books. Daniel Pink has a great book. It's called To Sell is Human. I kind of approach it like a human nature kind of puzzle. If you try to make it a game, it's easier for me to do that. And I was probably more introverted, before I even started this. You kind of develop things. I'm not saying I have multiple personalities right now, but we're doing just fine over here. But just practice at it. This is not something, and it's awkward at first. The first couple of times I gave my speech as to what DPC was, like as soon as I stopped talking, I was like, that's the dumbest thing I've ever said. You will get better. Practice. They don't care if you're introverted or not. They want to know who you are. You need to sell yourself. And some people are introverted. I've got plenty of patients that are introverted, and they like their hell is to come and sit in front of somebody and talk. But you have to let them know who you are, because they're buying you. They don't care where you practice. They don't care if it's out of the freaking van that you have. They want to know who you are as their doctor. And once you get used to doing that, it comes easier. But there's a saying in business, you grow when you're uncomfortable. And like, it pains me. I have to like psych myself out in the mirror every time I go to one of these Chamber of Commerce like things. Like they have like get-togethers and meetings and meet and greets and all sorts of stuff. I like have to stand there and be like, you're going. You have to go. You have to go, so you're going. And I'm like, all right, fine. And every time I go, I get one or two patients out of it, like every time. And I'm like, you did this last time. You got to go. I'm like, all right, fine. So the more you get out and go and put yourself out there, they've never seen a doctor out in the wild. Like they're interested. And so they'll come and talk to you, and you say, hey, yeah, I'm Dr. Williams. I run the direct primary care practice. I'm pretty much a subscription-based physician clinic thing going on. And I won't get into it now, but you'll develop the skill to like find out what is pissing them off about the healthcare system, and just driving that in there. Because not everybody's going to be like, you hone your speeches to who you're talking to. Not everybody cares that you can save them $1,000 on their annual lab visit or whatever. But if some mom comes in and she's irritated that the pediatrician kicked them out because they wouldn't get the vaccines, there's a pain point. I can get them every time. So I don't know if that answered anything, but I'm introverted. It's worked. You can do it. Yeah.
Sure.
Yeah.
I would just add too, like, your white coat is a symbol that you worked really, really hard to get. A lot of years went into getting that white coat, right? And wearing that stethoscope and being proud of being a physician. Now you just got to go out there and tell people that that's what you are, and that's what you want to represent in your community, and be strong at it. I always think about physicians, and this is not very, very good correlation, but police officers and firefighters, when they walk in a room, people take notice and they wonder, why is that person there? Same thing with a physician. And you walk into a room in that white coat, or even your scrubs, right? And people are like, huh, that's interesting. I never really seen a physician walk into XYZ before, and you really catch people off guard, and they start asking, well, why are you here? Is everything okay? And then now your door's open to really start to talk about what you are doing with your practice and who you are, and why you've decided to go down this journey to put patient care first.
I would also say that, emotion, the people that you're talking to can feel your emotion. So if you're jacked up about it, like if I'm walking into somebody and I'm like, yeah, I'm Dr. Williams, I run a DPC clinic, it's over there, they're going to be like, what? But if I come at it like, oh, you want to feel better? You want me to fix you? This is how I do things, and like get jacked up about how I save people money and, do better care. They feel that emotion come out, and you're gonna want to be with somebody that's animated and compassionate about what they're doing. It's real easy to sell something if they can feel your passion like coming through it. Introverted, yes, also passionate about being the best doctor for my patient. So that emotion overrides my selfish desire to be in a corner and not do anything.
That's a great visual. Susan, can you talk a little bit about what Freedom can do to support that? I know there's a lot that Freedom does to support people launching. What's your advice to the person who's a little scared to get out in their community?
Yeah, sure. I think the biggest thing is you have to make the first step. Your first step's always your hardest step, right? No matter what it is. I mean, I tell my 9-year-old, he's trying to figure out multiplication. I'm like, your first step is trying to figure it out and know the next step is coming. But once you get the first one, you're golden. You know how to do the rest. It only takes that one time to really step out, stand on your own 2 feet, have your speech prepared, and go into that space and start talking about it. Medicine, you know how to talk about that. When somebody says, oh my gosh, I can't even get a refill from my doctor. Well, what do you say? Hey, I don't have to go through 3 levels of phone trees to get me. You just call me right now. You can text me, have virtual visits. It's very simple. And patients don't even realize at this moment how easy it is for them to be in a practice and be able to be taken care of in this manner, because the system is kind of such a hassle and there's so many barriers for those patients. So they're really willing to listen to what you have to say and how you're going to help them.
Awesome. Well, thank you guys for answering our questions. That was our last of our questions. I'm going to pass it back over to you, Susan, and
Sure.
Thank you again.
Sure. I think I just had a couple little things, kind of going back to the residents for a minute, because I know we have some of those listening. Looking back at your journey to get to this point, if you saw your younger self, what would you say to yourself?
Regarding what? Because I was very difficult to talk to as
So
a resident.
like coming in, like you're done with medical school, you've done residency, now you got this crossroads, like you're going to the hospital, you're going to private practice, open your own thing, like kind of looking backwards, what kind of advice or journey or tips, tricks, information that you would share with the younger Dr. Williams?
The younger Dr. Williams was, let's just say, more difficult to work with. I mean, I don't know. Some people may have easier times with residency. I just hated every second of it. Yeah, I was one of those guys. But I mean, I don't know. I just, knowing my personality, I think it worked out the way it was supposed to. Because if you would have come to me as a resident and said there's a way to only see 5 patients a day and have your time to do whatever you wanted to and run your own practice, it's still hard work. It's just different kind of hard work, and resident hard work is like just being absolutely torched with just notes and seeing patients and being up at 4:30 in the morning to go deliver babies. It's just chaos. And if you would have told me, hey, after residency you're going to go start and run your own business, I'd been like, wait, what am I doing? I just want to see patients. So I understand that angle, and
Sure.
Knowing me, I would have this is just the way my life has been. I need to do it wrong before I see the light. And that's exactly how it worked out. And seeing it that way gave me a contrast to, the dark and what it is now, the light. And that's why I'm saying these residents that are already thinking of DPC are just way ahead of me in every aspect. That is just brilliant. I hope you don't need that negative experience. But I mean, bad news is for y'all that are already thinking about it, you're not going to stop thinking about it. So if you if you do go into fee for service, like every time you see somebody, every time an administrator comes to you and goes, you're spending more than 7 minutes with this patient, you need to tighten it up and get your notes in on time so we can send the claims. Like, that thing is going to be a thorn in your side, because thankfully for me, ignorance was bliss for a while. I didn't know there was a different way. Unfortunately for you guys, you already know that there's a light side out there. So it would have been way easier had I known that this thing existed before. I just can't give that a good answer because I just don't know.
Yes.
Because my mind was just mush by the end of taking the boards, and at the end of residency, you're just a different person.
Sure.
But like I said, if you're a resident already thinking about this, like, good for you, because you are going to you get at least 2-3 years of your life back. So good for y'all. But resident Dr. Williams, I mean, hopefully none of my co-residents or attendings are watching this, because they're going to be like, this freaking guy. Yeah, it was a nightmare. But
well, that's good. So I have one question left, and I get this question a lot, is call, right? How is your call now with your patient volume that you have, even from day one to where you are now, a little more than a year in? Like, what's your call volume? I mean, stressed out about it?
Yeah, I'll try to help out with this. As a as a resident, call was insane. You had to be, at the for us, you had to be at the hospital 24 hours, Q3 every 3 days, or three or 4 days, you had to be on 24 hours. And fee for service, when I was hired, I was like, I don't want call. And they're like, oh yeah, cool, come on. And then, like, as soon as you signed it, as soon as the honeymoon period was over, they're like, oh, we're going to put you on call Q7. I was like, hold up, I didn't want to be on call. And they're like, oh, well, if you read your contract, it says we can put you on call because it's, we have to, because of Medicare, Medicaid, or whatever BS reason they give. I was like, well, that's not what I signed up for. They're like, oh, sorry. So that was kind of garbage, and I was angry at that. And kind of, as soon as 5 o'clock hit, I would be like, done, and go home and try to get some food and go to sleep, and then redo it all over again. But technically, you're supposed to be available to them. When I started this, the DPC practice, you start off with a few patients. They have access to you anytime they need it. But I would recommend setting expectations real soon, and like at their new patient visit, be like, hey, you have access to me, don't abuse it. Because you're my patient doesn't mean you're my best friend. Okay, like, I want to be available to you for doctor stuff. If you send me another picture of your birdhouse at 3 a.m. on a Saturday, I'm probably going to fire you. That's the example, because
Is that a real example?
it happened. Yeah, and I was just like, this is inappropriate. And they're like, oh, I thought you wanted to know. I was like, no, I don't want to know. I do not care about this. There's some apps that you can have that you can have like an emergency or an urgent button that they can push at any time. Once again, you can set expectations. My patients know that if it's a medication refill, it's going to get looked at on Monday. But I mean, if they have their appendix rupture, please press that urgent button, because that's what I'm here for. It's the call is not, it's not real call, because they're your patients. It's weird with DPC. Once they become your patient, it's like they're your people. So you want to be available to them. And I get angrier when they don't call me, and they're like, oh, hey doc, I broke my arm 3 days ago, just didn't want to bother you. I'm like, no, you can bother me with that. But you just have to set expectations so they don't harass you in the middle of the night for something that could have been taken care of in the morning, or, you just have to let them know. Most of them are cool, and most of them are okay with sending you a message knowing that it'll be taken care of in the morning. So at 5 o'clock, my phone goes on silent, but if they have an urgent issue, it gets pushed through and alerts me. You just have to set those expectations, and I would highly recommend doing that. The sooner the better, because less feelings get hurt.
Sure.
Hopefully that answered it.
Yeah, I think so. I think, like I said, I think a lot of times when docs or providers are coming from that hospital employment, they ask that, right? They're always nervous of like their phone's going to be blown up all night long and all that
No.
kind of stuff because they're the only one there. So that was a great answer that you shared. Okay, well, we're kind of at the end of the hour at 6:30. If there's any final questions, we can hang on for a couple minutes just to answer those final questions. We appreciate Dr. Williams's time. And thank you, Sarah, for being here and going over this and helping these docs walk through this journey and really giving them their knowledge that they need, that they can do this on their own and be there. And Freedom will be there with them, and they have questions, we're here to help them. So thank you, everyone. And if you have any questions, by all means, you're more than welcome to reach out to myself or Sarah or Dr. Williams. If he has some time to answer questions by email, I'm sure he would be happy to do that as well. But thanks for joining us tonight. And we really appreciate your time and being here with us, Dr. Williams. Thank you.
Yeah, thank you all. Appreciate it.
Thank you. Have a good night.
Good night.